Hi, I'm Micah Long. I have a good ventilator case for everybody to work through today. Here's the case. Now, whenever I start to look at ventilator waveforms, I always try to figure out what mode I'm in and whether it looks like a textbook or not. And so you can see I left the name up there and I see that it's volume control. And whenever I'm in a volume control or pressure control, I try to remember in my brain whether the vent is controlling the pressure, which is this top line here, or whether it's controlling the airflow, which is this green line in the middle here. And in volume control modes, the ventilator controls the airflow, and it's a fixed amount of flow. And so here's the tidal volume. Let's pretend that's 500 milliliters. Here's a 500 milliliter tidal volume. You can see it doesn't change. It's very fixed. It's fixed by the ventilator, and we have fixed it in a decelerating flow pattern compared to a Darth Vader breathing pattern you can learn about in my other videos. When the flow is fixed, the pressure is variable. Vents aren't that challenging or smart. They're very dumb tools. They either control the flow or they control the pressure, and whichever one they don't control becomes the variable based on the patient in front of you, which you can learn about in all my other videos. So here we have a textbook flow waveform, and normally the pressure should either have that nice peak and plateau, or just like an alveolus balloon gets bigger, the pressure should go up over time. But I see that I have all these different weird pressure waveforms, so it does not look like a textbook. And here it is again. When I say what's not a textbook, we have a peak, moving down towards a plateau, but I have this big second pressure hit. And I also noticed that my not textbook appearance is that we breathe in twice before we breathe out at all. So what this patient is doing is called double triggering. And double triggering is where they breathe in, and then they breathe in again before they breathe out. And you can see red-green is Christmas, happy, and that means the patient is triggering these breaths. Most of our ICU ventilator modes are assist control, which means if the patient triggers a breath, they get the breath that you've set. So again, let's pretend this is 500 milliliters. They get 500 milliliters over a set amount of time in a decelerating format. And here they trigger again, they make a respiratory effort, and they get another 500 milliliters. So their total tidal volume is going to be double that. It's called double triggering. Double triggering has real differences in its causes that change how we manage it. The two core things you need to think about for double triggering are when the patient is driving the phenomenon and when it's a reflex action of the diaphragm. Patient driven is effort related. You have a tiny tidal volume and they want more, or you have a metabolic acidosis and they're trying to breathe that acid off, or they're in pain and trying to breathe fast. Lots of reasons why the patient might want a higher minute ventilation or bigger tidal volumes. But what you see when it's patient driven is that they're going to trigger every single breath. They'll have a higher respiratory rate. They might look like they're working harder to breathe, or otherwise be trying to maintain a higher respiratory rate and minute ventilation than what you've set on the ventilator. In contrast, reverse cycling is this very passive thing, and you see it in patients who aren't doing much, who are more sedate, and in fact often have bigger tidal volumes. Reverse cycling is a really weird phenomenon. It's passive, and it's a reflex, just like your patellar reflex, where when you hit the patellar tendon, your muscle flexes. It's a backwards reflex at the diaphragm. It's when you passively stretch the diaphragm with a mechanical ventilation breath. They breathe in, and then you release it. You start exhalation. When you release it, the diaphragm flexes. It contracts in a reflex way, and what the ventilator sees is that you're trying to breathe. It sees diaphragm flexion as breath. So while the patient might not be doing it, the ventilator doesn't know that or not, and the diaphragm then reflexively contracts. It looks like a breath, but it's not, and that's called reverse cycling. Let's take a look at whether we think this patient has double triggering due to effort or whether they are reverse cycling. When I look at this, I notice the same problems from the first video I showed. In fact, it is the first video I showed. Let's play it again. And what I notice is the patient breathes the first breath, they breathe the second breath, they breathe the moment they hit their expiratory flow of 0. So they're breathing the moment they've breathed out all the way. And if we look at our respiratory rate, it's 22. I've cut it off here, but I think our set respiratory rate is 14, so they're breathing quite a bit above. To me, this looks at first glance, without seeing the patient, as somebody that is effort driving, double triggering on the ventilator, not passive reverse cycling. That's my best guess. It's not always this clear at the bedside, but on this flow waveform, that's my best guess. Again, double triggering, patient driven, or effort related. If it's the diaphragm reflex, they're often more stretched, so bigger tidal volumes, and more sedate. This doesn't happen in awake people. You've never had a passive diaphragm reflex that you can think about or remember in your day-to-day life. Same thing at the ICU patient in front of you. All right, here's another one. Double triggering or reverse cycling. Let's take a look. This time I see very similar waveforms, very similar mode. We see the pressure spike with the second breath because they're getting big tidal volumes. It's double the tidal volume that you think you're setting, right? So if you're getting 2 breaths back to back of 500 milliliters without breathing out in between, you're going to get a 1 liter tidal volume here. We see a couple of these doubled up breaths. Our tidal volume's 450, so there's 450, 450. We're 800 to 900 mil tidal volumes here. Big breaths, and we see that in the pressure waveform. What I notice is that the patient is not triggering the first breath. They have some breaths that are not triggered at all. They ride the vent, and then have a contraction. To me, this is almost certainly reverse cycling, passive, sleepy patient who's maybe over sedate and should be lightened up. This is really bad for your diaphragm and for your well-being. And so I would wake these patients up. You try to minimize the stretch of the diaphragm, but mainly if you have reverse cycling, you wake them up as much as possible. If that doesn't work, this is a dyssynchrony that some people consider neuromuscular blockade or paralysis for. I don't like to paralyze when I can avoid it, but certainly don't like ventilator dyssynchrony either. So when I do have this and I can't fix it, which mode is safer, pressure or volume control? Here's a couple pictures. We've been looking at volume control double triggering this whole video. That's shown in the bottom right. Big tidal volumes, big pressure spikes. Pressure control shown at the left. If we double trigger on pressure control, remember the vents are not smart. They deliver a fixed pressure for a fixed time. You set it. So they get 12, for 1 second or whatever the I time is here. So 12 for 1 second. They get 12 for 1 second after. And the second breath is going to have a smaller tidal volume. So instead of spiking the pressure and having a big tidal volume in a pressure mode when you double trigger often, the second breath is smaller because they start that breath with more full and therefore less compliant lungs. And if you apply the same pressure to less compliant lungs, the volume goes down, as you've learned in my other videos. So in general, when you are double triggering, try to figure out if it's passive reverse cycling or active due to the patient. If it's due to the patient, fix the underlying condition. Try to work towards fixing their acidosis. You may decrease their respiratory drive with a narcotic if you can't fix the acidosis and want to deal with this. You also want to make sure you're on the right tidal volume for the patient in front of you, which is a bigger discussion than the video today. But generically speaking, pressure control is much safer for double triggering. If you're on volume control, you can really pop a pneumo and have spiking pressures with this. Happy ventilating. Hope everybody has a fantastic day.